Imagine for a second that your own immune system just suddenly declares a localized war on your body.
Yeah, which is terrifying enough on its own.
Right. But it doesn't choose a highly visible battlefield, like, your arms or your face.
Yeah.
It chooses the most sensitive, vulnerable, highly innervated tissue you possess.
And because of exactly where it happens, I mean, people suffer in silence for literally years before they even know what's attacking them.
Exactly. So welcome to today's deep dive. We are looking at a stack of clinical guidelines, medical articles, and patient resources, all centered on a highly misunderstood condition called lichen sclerosus, or LS.
It's a heavy topic, but such an important one.
It really is. And for you listening, our specific mission today is incredibly targeted. We're going to unpack the physical reality of an acute LS flare-up, zero in on the agonizing micro-fissures it causes, and most importantly, we're going to map out the precise clinical healing timeline you need to expect when treating them.
Yeah, and honestly, that timeline is going to be the most vital piece of knowledge we can offer today. Because if you look at the data across our clinical sources, lichen sclerosus, it sounds like a rare, obscure medical term.
It totally does.
Right, but it's actually one of the most common conditions treated in vulvar dermatology clinics worldwide.
Wow, really?
Oh, yeah. It is a chronic inflammatory skin disease. And I think to set a baseline before we really get into the mechanics of those fissures, the medical literature is adamant about dispelling the myths right off the bat.
Right, the misconceptions.
Exactly. So this is not a fungal infection. It is not a sexually transmitted disease. You cannot catch it, and you cannot pass it to a partner.
Which is a huge relief for a lot of people to hear, I'm sure.
Absolutely. And it has zero connection to personal hygiene. It is, at its core, an autoimmune condition. It's basically where your white blood cells, misidentify your own healthy skin cells as a threat.
Okay, so if it's an internal immune system malfunction, I guess my first instinct is to picture a systemic reaction, like a rash breaking out all over your body.
Yeah.
But that's not what happens here, right?
Oh, no, not at all.
So what is the immune system actually doing to the tissue in this specific disease?
It's remarkably hyperfocused. The primary target is the anogenital region.
Okay.
So in women, the immune system homes in on the vulva and the perianal area, which is the skin directly surrounding the anus. And dermatologists actually look for a very distinct visual cue. They look for this pale figure of 8 pattern that literally loops around those two anatomical areas.
A figure of 8, okay. And what about men?
In uncircumcised men, the attack is usually concentrated on the glands, so the head of the penis and the inner lining of the foreskin.
But, why there? If my immune system is circulating through my entire bloodstream, why is it launching this massive offensive on such a localized, specific postcode of my body? Like, do people ever get it on their elbows or their knees?
They do, actually, but it's the exception rather than the rule. Yeah, the clinical data shows that in fewer than 20% of cases, patients do develop extragenital lesions. You might find these specific patches on the neck or the upper chest, the shoulders, maybe the wrists.
We just never hear about those extragenital cases. I assume because a patch of inflammation on your shoulder is a lot easier to ignore than one in your genital region.
Well, it goes a bit deeper than just being easy to ignore. The extragenital patches are usually entirely asymptomatic.
Wait, they don't hurt at all?
No, they rarely even itch. You have to think about the environment. The skin on your shoulder, it's exposed to the air. It's relatively dry.
Right.
It isn't subjected to constant high-pressure friction, trapped moisture, or, daily exposure to bodily fluids.
That makes a lot of sense.
Yeah, the genital tissue is a uniquely demanding environment. It relies heavily on elasticity just to function normally. So when the immune system attacks that specific area, it fundamentally alters the physical architecture of the tissue.
Let's break down that architectural change. Because if the immune system is attacking the skin cells, it's not just making it red and inflamed like a typical rash, is it?
Sure.
The sources describe a very distinct physical transformation.
Yeah, it's more like a complete structural breakdown.
Wow.
Chronic inflammation basically acts like a wrecking ball to the deeper layers of the skin. It destroys the elastic fibers, the elastin, and it interrupts the normal production of healthy collagen.
So it's tearing down the scaffolding.
Exactly. And as a result, the skin becomes severely thinned out. It loses all its stretch, all its resilience. It also loses its normal pigmentation, turning this striking pale, porcelain white color.
Okay, so it gets thin and white.
Right. And because the underlying dermal structure has essentially collapsed, the surface of the skin crinkles. The medical texts universally rely on a very specific visual comparison to describe this. They say the skin takes on the appearance of crinkled cigarette paper or wax paper.
Cigarette paper. That visual immediately shifts your perspective.
Hmm.
You go from thinking about a tough, resilient organ like normal skin to something so fragile you could tear it just by breathing on it.
Exactly.
And if that cigarette paper skin is located in a high-friction environment, that just feels like a recipe for absolute disaster.
Oh, it is. It's the catalyst for the most agonizing phase of the condition, which is the acute flare-up. This is where the disease transitions from a quiet structural change into a physically debilitating reality.
Yeah, because according to the patient resources we reviewed, the flare-up is dominated by one overwhelming symptom: itch.
Yes.
But reading these accounts, they aren't describing a mild irritation. Like, they aren't talking about a mosquito bite.
Or at all. The hallmark of an active lichen sclerosus flare is the severe, maddening, intractable itch that just goes deep into the tissue. And biologically, this itch follows a very cruel pattern. It is almost universally reported to be intensely worse at night.
Why night? Does the immune system just operate on a clock?
In a way, yeah, it kind of does. So your body's natural cortisol levels, and cortisol suppresses inflammation, those levels drop in the evening.
Oh.
Plus, there are just fewer sensory distractions.
Oh.
During the day, your brain is processing a million different inputs. But at night, lying in bed, your central nervous system has nothing else to focus on except those inflammatory signals firing in that local tissue.
That sounds like torture.
It is. Patients will often scratch aggressively in their sleep without even realizing they are doing it, only to wake up in severe pain.
Which brings us to the mechanical reality of this. If your skin is currently the consistency of wet cigarette paper, and you drag your fingernails across it in the middle of the night, you are going to destroy that tissue.
Precisely. And the thing is, it doesn't even require aggressive scratching, just the minimal friction of everyday life. I mean, sitting in a chair for a few hours, wiping with toilet paper, or just the seam of tight clothing rubbing against the area, it all leads to immediate mechanical trauma. The skin simply cannot withstand the tension. It gives way, creating micro-fissures.
I was reading about these micro-fissures, and I think the best way to visualize it isn't a cut. It's not like slicing your finger with a knife.
Yeah, oh no.
Think about an old, completely dried out piece of parchment paper. If you let it rest flat on a table, it looks perfectly intact. But the absolute second you try to bend it or stretch it or apply any tension whatsoever, it simply splits open.
Yeah.
It just lacks the biological elasticity to accommodate movement.
That is the exact mechanical failure happening in the tissue. You get these microfissures, which are tiny linear tears. You also develop erosions, which are these shallow, open, weepy sores where the top layer of skin has just sheared right off.
Ouch.
And you see purpura, which is basically localized bleeding and bruising, trapped just beneath the surface of that thin skin.
And now we have to combine that parchment paper splitting with the environment we talked about earlier. When those microfissures open up in the genital region, they are immediately exposed to biological fluids.
Right. Think about the chemistry of human urine. It is highly acidic and it's heavily concentrated with urea salts. So when a patient with active, open microfissures urinates, those acidic salts wash directly over what are essentially exposed nerve endings.
Oh, man. I mean, that isn't just uncomfortable. That is a chemical burn on a live wire.
It really is. It triggers a severe localized pain response, stinging and burning that can linger for hours. And the trauma isn't limited to urination either. We have to look at the perianal involvement.
Right, the skin around the anus.
Exactly. If the tissue around the anus is thinned out and fissured, the mechanical expansion required to pass a bowel movement causes the skin to literally tear open.
And the pediatric literature we have actually highlights this as a major hidden crisis. Young girls who develop lichen sclerosus experience this severe tearing pain when they use the bathroom. So what do? They do what any kid would do to avoid pain. They start withholding their stool. They just refuse to go.
Which creates this horrific vicious cycle. Withholding leads to severe chronic constipation. So the stool becomes harder and larger, and when they finally are forced to pass it, the mechanical trauma and tearing are exponentially worse.
It's heartbreaking.
You have children undergoing massive gastrointestinal workups for constipation when the actual root cause is an autoimmune skin condition that, quite frankly, a pediatrician might not even be trained to look for.
And for adults, the mechanical failure of the skin obviously devastates intimacy.
Yes. The clinical term is dyspareunia, which means painful sexual intercourse. The friction of penetration on skin that has lost its elasticity inevitably causes it to split, tear, and bleed. And the psychological distress this causes, it really cannot be overstated. It puts an enormous strain on relationships, leading to anxiety, avoidance of intimacy, and just a profound sense of isolation.
Which brings us to the absolute core of our deep dive today. If you are listening to this and you are trapped in the middle of a flare-up, you have the sleep-depriving itch, you have these parchment paper micro-fissures, you have the stinging from the urine and the pain, your central desperate question is, what is the typical healing timeline for these micro-fissures? How fast can I fix this? Let's lay out the clinical gold standard for treatment.
Yeah, let's do it. So if you consult the international guidelines, whether it's the European Dermatology Boards, the British Association of Dermatologists, or the U.S. clinical standards, they are totally unified on this.
Okay, good.
The singular gold standard treatment is the application of ultra-potent topical corticosteroids, and the most universally cited medication is clobetasol propionate, specifically the 0.05% ointment formulation.
Okay, let's pause and push back on that logic for a second, because this is where a lot of patients feel a massive disconnect. If you read the warning insert on a tube of ultra-potent clobetasol, it usually features a giant, bold warning that says, do not use on thin or sensitive skin. Long-term use causes skin thinning.
Yes, it does.
But we just established that lichen sclerosus has already caused the skin to become as thin as cigarette paper. If I have tissue paper skin, my instinct would be to prescribe a growth hormone or estrogen or something to stimulate cell growth. Why are we applying a medication known to thin the skin onto skin that is already dangerously thin?
It's a great question, and this is the exact paradox that causes rampant steroid phobia among patients and honestly even among some general practitioners. It is the #1 reason people abandon their treatment.
I totally get why.
But you have to look at the cellular mechanism of what is actually happening. In a normal, healthy person, yes, blasting the skin with ultra-potent steroids will eventually inhibit collagen production and thin the skin out. But a patient with lichen sclerosus does not have normal skin. Their skin is incredibly thin because a localized immune system fire is burning through the architectural support.
Oh, I see. So the steroid isn't acting on healthy cells, it's targeting the immune response itself.
Exactly. The steroid molecules actually penetrate the cell walls, and they inhibit the specific genes that are producing the inflammatory chemicals. It basically pulls the plug on the immune system's communication network in that targeted area.
Wow.
And once you shut down that localized civil war, the skin cells finally have the peace and quiet they need to naturally rebuild their collagen, restore their elastin, and thicken back up.
That makes total sense when you frame it like that.
The clinical data is unequivocal here. Active, untreated inflammation will cause infinitely more permanent thinning and damage than a carefully managed regimen of topical steroids ever could.
That distinction is huge. You aren't thinning the skin, you are putting out the fire that is thinning the skin.
Yeah.
So let's get into the mechanics of the timeline. I have my tube of clobetasol ointment. What does day 1 look like? How much am I actually using?
Precision is key here. You don't use it like body lotion.
Right.
The guidelines specify a pea-sized amount, or what clinicians call a half fingertip unit. That's literally a line of ointment from the tip of your index finger to the first crease.
That's tiny.
Very tiny. And you apply this exclusively to the white, inflamed, or fissured patches. You do this once a day, optimally right before bed, to combat that nocturnal itch cycle we talked about.
Okay, day 1, pea-sized amount at night. When do I actually feel the fire go out? Like, when does the itch stop?
The timeline for symptomatic relief is fairly consistent. For the agonizing irritation, the burning, and that relentless deep tissue itch, the relief typically sets in right around the 2-week mark of daily application.
Okay, so 2 weeks to stop the itch. But what about the structural damage? What is the specific healing timeline for those agonizing micro-fissures? Because that's the real focus here.
Right, and here is where we hit the most critical clinical deadline in all the literature. According to the medical guidelines, those painful micro-fissures must be seen to heal and close up within 3 weeks of daily ultra-potent steroid use.
3 weeks. That is a highly specific, very rigid window. Let's say a listener is applying the clobetasol religiously. They hit day 21, the itch is mostly gone, but they look, and those fissures are still open. They aren't healing. Why is the 21-day mark a clinical red flag?
Because that 3-week rule isn't just about tracking your comfort. It is a vital diagnostic safety net. Clobetasol is one of the most powerful anti-inflammatory agents we possess. If you have a fissure, an erosion, or an ulcer on the vulva or the penis that refuses to close up after 3 solid weeks of that medication, it strongly suggests that the wound is no longer just the result of inflammation.
Wait, what is it?
There is likely something else happening at a cellular level.
Meaning the cells themselves have fundamentally mutated.
Precisely. If fissures don't heal in that 3-week window, or, if during your application you feel any new persistent lumps, hard nodules, or raised ulcers that weren't there before, the guidelines mandate an urgent referral back to a specialist for a tissue biopsy.
Because they need to rule out cancer.
Yes. They are looking for malignant cellular changes. Lichen sclerosus carries a 3 to 5% lifetime risk of developing into squamous cell carcinoma, which is a specific type of skin cancer.
I want to make sure we contextualize that number because hearing the word cancer immediately spikes anxiety.
Of course.
A 3 to 5% lifetime risk means that 95 to 97% of people with this condition will never develop cancer from it.
That is correct. The absolute risk for any individual patient remains low. However, we have to look at the other side of the statistic. Approximately 60% of all vulvar squamous cell carcinomas arise on a background of lichen sclerosus.
60%? Wow.
Yeah. Why? Because chronic, uncontrolled inflammation, combined with the continuous mechanical trauma of daily scratching and tearing, constantly forces the cells to rapidly divide and repair themselves. And over years and years, that rapid division increases the chance of DNA errors, which leads to malignancy. That is why treating the flare-up isn't just a quality-of-life issue. Hitting that tissue with steroids to shut down the inflammation is active, frontline cancer prevention.
So the immediate timeline is super clear. 2 weeks for the itch to subside and a strict 3-week deadline for the micro-fissures to heal, or you get a biopsy. But let's look past the acute flare-up. Let's say the fissures close on day 18. You're out of the woods for cancer. What is the long-term timeline? Does the pale cigarette paper skin ever actually return to normal?
It can recover significantly, but the timeline extends much further out. While the fissures close in weeks, the texture, the elasticity, and the normal color of the skin usually take up to 3 months of consistent treatment to fully regenerate. But that timeline assumes one very important caveat. It assumes the disease hasn't already caused permanent architectural loss.
We mentioned architectural loss earlier. In plain English, what does that actually mean mechanically? How does a surface inflammation permanently change the physical shape of the anatomy?
It comes down to how the body heals chronic damage. When the immune system continuously destroys the flexible elastic fibers, the body tries to repair the damage by dispatching fibroblasts.
Okay.
These cells lay down dense, rigid collagen, scar tissue, basically.
And scar tissue doesn't stretch.
It doesn't stretch, and worse, it contracts. It acts like a biological glue. If the inflammation rages on unchecked for years, this contracting scar tissue physically alters the anatomy. Tissues fuse together and shrink.
Oh.
In women, the labia minora, the inner lips, can undergo resorption, meaning they literally flatten out and disappear into the surrounding tissue. The scar tissue can grow over the clitoris, completely burying it, which severely impacts sexual sensation. The opening to the vagina can narrow and tighten so much that even clinical examinations become impossible.
And what about the mechanical failure in men?
In uncircumcised men, the biological glue of that scar tissue forms a rigid ring around the foreskin. This causes a condition called phimosis, where the foreskin becomes so tight and constricted it can no longer be retracted over the head of the penis.
That sounds awful.
It can even scar and narrow the urethra, making it physically difficult to pass urine. And if potent steroids can't reverse the fibrosis in time, the only remaining cure for men is often a surgical circumcision to remove the diseased tissue entirely.
So the stakes of ignoring a flare-up are incredibly high. You cannot just grit your teeth and tough it out. You are risking the permanent loss of normal anatomy, which leads to the final phase of the timeline.
Great.
What happens after the 3-month mark? Let's say the skin has regained its texture. The architectural loss was prevented.
Yeah.
You don't just toss the tube of clobetasol in the trash and walk away, right?
Absolutely not. This is a chronic autoimmune condition. It doesn't magically disappear. It just goes dormant.
Right.
So the standard clinical protocol usually tapers your usage down. You go from daily to alternate days down to twice a week. And that twice-a-week application becomes your maintenance therapy. The guidelines strongly recommend maintaining that 1 to 2 times a week application indefinitely, essentially forever.
It's the exact same logic as maintaining a classic car. You don't wait for the engine to completely seize up and start billowing black smoke on the highway before you decide to change the oil.
Exactly.
You do routine preventative maintenance every few thousand miles specifically to keep the engine lubricated and stop the catastrophic damage before it starts.
That's a perfect mechanical analogy, actually. Applying that tiny amount of steroid twice a week keeps the local immune system quiet. It prevents the inflammation from ever ramping up enough to thin the skin again. And long-term studies suggest this proactive maintenance routine is incredibly effective at preventing that 3 to 5% cancer risk we talked about.
Beyond the twice-weekly steroid, the clinical guidelines also heavily emphasize the daily use of emollients. These are like medical-grade, bland moisturizers like emulsifying ointments. But if the steroid is doing the heavy lifting by suppressing the immune system, what is the mechanical purpose of a simple moisturizer? Is it literally just to treat dry skin?
It is doing much more than just moisturizing. It serves two vital physical functions. First, it replaces soap. Standard body washes, bubble baths, and scented soaps contain surfactants that strip the skin's natural oils and cause severe irritation to fragile tissue. Patients are advised to only wash the area with lukewarm water or a gentle emollient wash.
Okay, that makes sense.
Second, the emollient acts as a physical waterproof barrier. Remember the chemistry of the urine? The acidic urea salts causing chemical burns on the micro-fissures?
Right, the live wire pain.
Yeah. So if a patient applies a generous layer of greasy emollient before they use the restroom or before they go for a run, they are laying down a thick lipid barrier. When urine or acidic sweat hits the area, it literally glides right off the waterproof ointment instead of penetrating the fragile skin and hitting those nerve endings. It is a highly effective, purely mechanical shield.
That is a life-changing piece of practical advice. You are essentially waterproofing the vulnerable tissue against your own biology.
Exactly. And to add one more layer of protection, particularly for patients going through menopause, doctors will frequently prescribe topical estrogen creams to be used alongside the steroid and the emollient.
Oh, because of the hormonal changes.
Right. The drop in systemic estrogen during menopause causes natural thinning and dryness of the vaginal tissues, which obviously compounds the fragility caused by the lichen sclerosus. Replenishing that local estrogen helps maintain the tissue's resilience, even though the steroid remains the primary engine driving the disease into remission.
Let's bring all this clinical data back to you, the listener. Lichen sclerosus is a chronic tissue-altering condition. And because of where it strikes, it can be deeply isolating, psychologically distressing, and intensely painful. But the main takeaway from all these medical sources is that you do not have to suffer endlessly, and you do not have to accept the permanent loss of your anatomy. If you are experiencing an acute flare-up, ultra-potent steroids are not your enemy. They are the exact tool you need to shut down the localized fire.
Just hold fast to the healing timeline. You apply that half-fingertip unit daily. You expect the relentless itch to begin fading around the 2-week mark.
And you enforce the golden clinical rule, the answer to our main question today. Those agonizing microfissures must close and heal within 3 weeks. If they refuse to heal, or if you feel new hardened nodules, you do not wait. You advocate for yourself, you get back to a specialist, and you request a biopsy to rule out cellular changes.
And once you reach remission, protect the architecture you have saved with twice-weekly maintenance steroids and a daily waterproof shield of emollients.
We have mapped out exactly the mechanics of how to treat this condition, how to heal the fissures, and how to stop the flare-ups in their tracks. But looking at the broader medical literature, there is a massive lingering question. We know how to suppress the attack, but we still don't actually know why the attack is ordered in the first place.
We really don't. We know there's genetic susceptibility involved, and we clearly understand the mechanics of the autoimmune response. But the initial catalyst remains a phantom. Like, what exactly triggers the immune system to suddenly, out of nowhere, declare this hyper-localized war on one specific type of genital tissue while completely ignoring the rest of the body?
It is a localized civil war, and the first shot fired is still completely invisible to us. It remains one of immunology's most fascinating unsolved mysteries. Researchers are actively trying to crack that code, but until they do, hold on to your timeline, trust the mechanics of your treatment, and don't let the flare-ups win. Thanks for joining us on this deep dive.